Imagine a ticking clock. But here's the catch. It's silent. It's tucked away right under your rib cage on the right side, completely hidden. It's doing its job day in and day out, storing bile, concentrating it, helping you digest that pepperoni pizza you had for lunch or the ice cream you ate, while watching a movie. You don't even know it exists. It's completely off your radar.
Completely.
Until suddenly it isn't.
And when it decides to make itself known, it doesn't whisper. It screams.
Right. A single small stone, sometimes no bigger than a pebble you'd get in your shoe shifts, just a few millimeters. It lodges in a tiny duct, and suddenly, a quiet Sunday afternoon turns into a frantic rush to the emergency room.
It really is that dramatic. In medicine, we often treat the gallbladder as this sort of vestigial throwaway organ. We say, oh, you can live without it, which is technically true.
Sure, people say that all the time.
But when you look at the pathology, when you look at what actually happens when this organ fails, it is fascinatingly destructive. It's a masterclass in how a simple mechanical obstruction triggers a massive biological cascade.
That is exactly what we are doing today. We are doing a deep dive into the silent stone. We are breaking down the pathology of the gallbladder. We've got a stack of clinical notes, surgical textbooks, and pathology reports right here.
We're going to trace how a simple stone leads to inflammation, how that inflammation turns into scarring, and how, in the worst-case scenarios, that scarring opens the door to something much darker.
We're going to trace the entire life cycle of gallbladder disease. It's a journey. We start with the chemistry, the formation of the stones themselves, or cholelithiasis.
Cholelithiasis, okay.
Then we move to the acute crisis, acute cholecystitis. We'll look at the long-term grinding damage of chronic cholecystitis, the bizarre visual anomalies like the strawberry gallbladder, and finally, the silent lethality of gallbladder carcinoma.
It's a journey from chemistry to catastrophe. So let's start at the very beginning. The stone itself. Cholelithiasis. The source material refers to them as solid concretions, which to me sounds remarkably like geology, not biology. It is a bit of geology happening inside the body. Cholelithiasis is just the fancy medical term for the presence of gallstones.
Okay.
And the most important thing to understand right off the bat, the headline here, is that these stones are the starting point for almost all gallbladder trouble.
So if you don't have the stone, you generally don't have the problem.
Usually, yes. The stone is the agitator. I mean, if you're looking at biliary colic, acute inflammation, chronic scarring, pancreatitis, or even cancer risk,
Yeah.
you usually have to look for the stone first. It's the villain in the story.
But they aren't all the same, right? I mean, a rock is a rock, but in the body, chemistry matters.
A huge difference. We categorize them into two main types based on their chemistry and, frankly, what they look like to the naked eye. First, and by far the most common in the Western world, you have cholesterol stones.
Yeah, cholesterol stones. I'm picturing something yellow, like a ball of fat.
You're spot on. They are yellow to pale in color. Sometimes they look like little pearls, sometimes like jagged yellow rocks. And they form because of a concept called supersaturation.
That brings me back to high school chemistry. Supersaturation is when you dissolve more solute in a solvent than it can theoretically hold.
Right. It's exactly that principle. Your bile, which is made by the liver, contains cholesterol. Under normal circumstances, that cholesterol is dissolved. It's liquid.
Right.
But if the liver secretes too much cholesterol or if the bile sits in the gallbladder too long, the solution becomes supersaturated.
Balance tips.
Right. The cholesterol can no longer stay dissolved. It precipitates out. It turns from liquid to solid, forming crystals.
It's like when you make iced tea and you put way too much sugar in it. You stir and stir, but eventually you just get that layer of sugar sludge at the bottom of the glass.
That is a perfect analogy. The bile becomes a supersaturated syrup, and eventually solids form. But the sources point out that it's not just about having too much cholesterol. It's a perfect storm of three physiological drivers.
Okay, let's break those down. Driver 1 is the supersaturation. Too much sugar in the tea.
Correct. Driver 2 is gallbladder hypomotility.
Hypomotility. Hypo meaning low, motility meaning movement. So the gallbladder is lazy.
It's stagnant. Stasis is the enemy here. The gallbladder is supposed to contract and squirt bile into the gut when you eat. If it doesn't pump regularly, the bile sits there. Stagnant fluid is a playground for crystal formation. It gives the crystals time to settle and bond together.
So if the fluid is moving, the crystals flesh out. If it sits, they build a fort.
Exactly. And then the third driver, nucleation factors.
That sounds like physics.
It sounds complex, but it's simple. Crystallization needs a kickstart. You need a seed. These nucleation factors are tiny particles, mucus, proteins, maybe a bit of bacteria that give the cholesterol crystal a platform to start growing on.
It's the grain of sand that starts the pearl in an oyster.
Precisely. So you need the ingredients, cholesterol, you need the lack of movement, stasis, and you need a seed, nucleation. If you have that trifecta, you get a cholesterol stone.
Now, you mentioned a second type. If it's not cholesterol, what is it?
The pigment stone, these look totally different. They are usually black or brown. They aren't made of fat. They are related to bilirubin.
Bilirubin. That's a breakdown product of blood cells, correct?
Correct. When your red blood cells die, which they do naturally every few months, they break down into bilirubin. The liver filters it out and puts it in the bile.
So while cholesterol stones are about diet and metabolism, pigment stones are blood issues.
Often, yes. Pigment stones are linked to conditions where you have a high bilirubin load. Things like hemolytic anemias, where your red blood cells are popping too fast.
Okay.
Or, critically, biliary infections.
Infections. How does an infection make a stone?
It's chemistry again. Bacterial enzymes can actually chemically alter the bilirubin in the bile, causing it to become insoluble. It precipitates as a stone.
Quick recap on the geology here. Yellow stones are usually cholesterol issues. Too much fat, lazy gallbladder. Black or brown stones are pigment issues. Too much blood breakdown or an infection.
You've got it. And the source material mentions a very specific risk profile for those yellow cholesterol stones. It's a classic mnemonic that every medical student learns in their first week of surgery rotation. The 4 Fs.
The Fs, I've heard this. Female, fat, 40, and fertile. It sounds a bit reductive, doesn't it? Like a stereotype.
It does sound blunt, but the science behind it is actually quite robust. It's largely driven by hormones.
Okay, let's unpack the science so it's not just a label. Right, female and fertile.
Estrogen and progesterone. Estrogen increases the amount of cholesterol the liver pumps into the bile. So women generally have more cholesterol in their bile than men.
Okay, so that's the supersaturation part.
Right. And progesterone, which spikes during pregnancy, slows down the emptying of the gallbladder. It causes that hypomotility we talked about. So female and fertile, implying reproductive age or multiple pregnancies, increase the risk because you have a double whammy.
Okay.
More cholesterol entering the system and a slower system flushing it out.
That makes sense. What about fat? I assume that's straightforward.
It is. Obesity increases the total cholesterol synthesis in the body. More cholesterol in the body means more cholesterol in the bile.
I am 40.
Yeah.
Why is age the trigger?
It's the time factor. Metabolic issues take time to manifest as a physical object. You don't form a 2-centimeter stone overnight. It takes years of that chemistry bubbling away before the stone is big enough to cause a problem.
So we've got our stone. It's sitting there in the gallbladder. Maybe it's been growing for 5-10 years. At what point does this geology project become a medical emergency? Because a lot of people have stones and never know it, right?
Absolutely. We call them asymptomatic stones. The majority of people with gallstones will live their whole lives and never have a symptom. The stones just float around in the gallbladder, minding their own business.
So what changes? What flips the switch?
The turning point, the moment a stone stops being a passive object and creates a disease state, is obstruction. This brings us to acute cholecystitis.
The acute event. The Sunday dinner disaster.
Yes. Here's the scenario. You eat a fatty meal, that pizza. The fat enters your small intestine. Your body senses the fat and sends a hormonal signal called cholecystokinin to the gallbladder. The signal says, squeeze, we need bile to digest this fat.
So the gallbladder contracts?
It contracts vigorously. But, bad luck, a stone gets caught in the current. It gets pushed right into the cystic duct. That's the exit pipe. And because the duct is narrow, the stone gets stuck.
Now you have a blockage. I assume that's painful.
Extremely. That's biliary colic.
Yeah.
But here is where it gets really interesting from a pathology standpoint. We tend to think, oh, it's blocked so it hurts, like a clogged sink. But the mechanism of injury in acute cholecystitis is much more complex than just a plugged pipe. It's not just mechanical, it's vascular.
Vascular, so it affects the blood flow.
Think about the physics of it. The duct is blocked, but the gallbladder wall is still trying to do its job. It keeps trying to secrete mucus and fluid, but nothing can get out. The pressure inside the gallbladder, the intraluminal pressure, starts to skyrocket.
It's blowing up like a balloon.
A tense, angry balloon. As that pressure rises, it pushes outward against the wall of the organ. Now, running through that wall are blood vessels. Arteries bringing blood in and veins taking blood out. Veins are low-pressure vessels. They are flimsy. Arteries are high pressure. They are tough.
So the pressure in the gallbladder squashes the veins first.
Exactly. The pressure collapses the veins. Blood can get in through the arteries, but it can't get out through the compressed veins. The wall swells with fluid edema. It gets boggy and thick.
And eventually, the pressure gets so high that even the arteries can't push blood in.
Yes. And that is the critical moment. When arterial flow is compromised, you stop getting oxygen to the tissue. That is ischemia.
Ischemia. That's the same thing that happens in a heart attack.
It is exactly the same mechanism. Tissue death due to lack of oxygen. The mucosal lining of the gallbladder starts to suffocate and die. This is the key takeaway that the sources emphasize. Acute cholecystitis is primarily an ischemic event caused by pressure.
That really changes how I picture it. I always thought it was an infection, like, oh, the gallbladder got infected.
The infection actually comes second. The sources call it superimposition. Once the tissue is damaged by ischemia, the protective barrier is broken. Your gut is full of bacteria E. coli and Enterococcus, and they might have been hanging around harmlessly. But once the wall is dying, they invade.
So the stone causes the pressure causes the ischemia kills the tissue, and then the bacteria move in to feast on the damage.
That is the chain reaction.
Visually, what does this look like? If you were a surgeon and you open someone up right at this moment, what are you seeing?
It's dramatic. Grossly meaning to the naked eye, the gallbladder is enlarged. It can be 2 or 3 times its normal size. It's tense. If you poke it, it doesn't squish. It feels hard because of the pressure.
And the color?
Angry. The surface, which should be a smooth, pale blue-gray, shows serosal congestion. It looks bright red, maybe purple. It's covered in dilated blood vessels.
And if you cut it open?
The bile inside might be turbid or cloudy. Instead of clean green fluid, it's mixed with pus and fibrin. And the lining, the mucosa, might be ulcerated from that ischemic damage we discussed. It looks like a war zone.
It sounds incredibly volatile. The source material uses a phrase that really stuck with me. It calls this state a complication engine, which is a terrifying way to describe an organ in your body.
It is terrifying, but it's accurate. Acute cholecystitis isn't just about pain, it's about structural failure. If you leave that ischemic, high-pressure infected organ untreated, the structure starts to break down. And that's when things get life-threatening.
Let's run through this list of complications because some of these are wild. First on the list, empyema.
Empyema is essentially when the gallbladder fills completely with pus. The bacterial infection takes over and the entire organ becomes a bag of purulent material. It's a severe enclosed infection.
Yeah.
You have a sack of toxic waste sitting inside the abdomen.
And then gangrenous cholecystitis. That word gangrene is never good.
Never. This is the natural progression of that ischemia we talked about. If the blood flow is cut off for too long, the tissue doesn't just get sick, it dies completely. Necrosis. The wall turns green or black.
And dead tissue has no structural integrity. It's weak, which leads to the next one, perforation.
This is the most dangerous complication. The wall bursts, literally pops. If that infected bile and pus spill into the abdominal cavity, you get generalized peritonitis. That is a widespread infection of the lining of the abdomen. That is a surgical emergency with a high mortality rate if not caught immediately.
Okay, those seem logical. Pressure leads to death, death leads to bursting. But then there are these 2 complications in the notes that involve the gallbladder interacting with its neighbors, specifically the cholecystoenteric fistula.
This is fascinating pathology. Imagine the inflamed gallbladder. It's hot, sticky, and angry. It's sitting right next to the duodenum, the first part of the small intestine.
They're neighbors.
Right. Because of the inflammation, the gallbladder literally sticks to the bowel wall. Adhesions form. Over time, the inflammation eats through the gallbladder wall, and then it eats through the bowel wall attached to it.
It tunnels through.
It creates a tunnel, a fistula, an abnormal connection forming directly between the gallbladder and the bowel.
So now you have a trapdoor.
Exactly. And remember our stone, the one that started all this trouble.
The big one.
If that stone is large enough, it takes the trapdoor. It bypasses the bile ducts entirely. It falls out of the gallbladder and drops straight into the intestine.
That sounds better. I mean, the stone is out of the gallbladder.
You would think. But now you have a large rock traveling down a tube that gets narrower and narrower. This leads to the final complication in this segment, gallstone ileus.
Gallstone ileus. This is the one that always surprises me.
It's a mechanical obstruction of the bowel caused by a gallstone. The stone travels down the small intestine. It tumbles along until it hits a narrow spot, usually the ileocecal valve, where the small intestine meets the large intestine.
It's a bottleneck.
It is. And the stone is too big to pass, so it plugs the bowel.
So you have a patient presenting with a bowel obstruction, vomiting, distension, no bowel movements. But the cause is a rock from their gallbladder that took a secret tunnel.
Precisely. It's a perfect example of how pathology connects different systems. You start with a gallbladder problem and end up with a bowel obstruction.
That is wild. It really shows how interconnected everything is. Okay, so that's the acute side of things. The storm, the crisis, the blowout.
Right.
But what if the stone doesn't cause a total blockage? What if it just kind of rolls around, causing trouble on and off for years? That brings us to chronic cholecystitis.
This is the long game. Chronic cholecystitis is defined by long-standing inflammation. It's almost always associated with stones, but the mechanism is different. Instead of one massive crisis, it's repeated low-grade injury.
It's a slow burn.
Exactly.
And the clinical picture is different too, right? It's not a sudden emergency room visit with a bursting organ.
Usually not. The classic pattern is repeated episodes of pain. The patient will tell you, "Doc, every time I eat fried chicken or cream sauce, I get this ache under my ribs for a few hours, and then it goes away."
The gallbladder contracts, hits the stone, hurts, then relaxes, and the pain fades over and over again.
For years, and this constant cycle of irritation and healing changes the organ.
How does this change the look of the gallbladder compared to the acute version? Because in the acute version, you said it was big, red, and swollen.
The chronic gallbladder is almost the opposite. Remember, acute was edema fluid swelling. Chronic is fibrosis scarring.
So it shrinks.
It shrinks. Years of inflammation lead to the deposition of collagen. Scar tissue contracts as it matures, so you end up with a small, hard, thick-walled organ. The wall becomes leathery.
It loses its flexibility.
Completely. Microscopically, you don't see the acute swelling and congestion. You see a chronic inflammatory infiltrate, lymphocytes, plasma cells, and dense fibrosis in the wall. The muscle layer might even be hypertrophied, thickened from trying to push against those stones for so long.
And this chronic scarring leads to one of the most evocative terms in pathology, the porcelain gallbladder.
This is an exam favorite and a critical clinical concept. Sometimes, as part of that chronic healing and scarring process, the body does something strange. It deposits calcium in the gallbladder wall.
Calcification.
Dystrophic calcification, to be specific. It's the body's way of walling off damaged tissue.
So the wall literally turns to stone.
In a way, it becomes hard and brittle. If you were to tap it with a surgical instrument, it would make a clicking sound. It looks and feels like bluish-white ceramic, hence porcelain gallbladder.
It sounds delicate and almost beautiful, porcelain, but the implication is not good.
Not good at all. The reason we care so much about porcelain gallbladder is not just because it's weird. It's because it has a strong association with an increased risk of gallbladder carcinoma.
It's a red flag.
It's a massive neon sign. It tells us this organ has been under siege for a long time. The cells have been irritated, damaged, and repaired so many times that they are starting to behave unpredictably. DNA damage accumulates.
We're going to get to carcinoma in a minute, but before we go to the dark side, there's one more visual anomaly in the notes that we have to talk about. It has a great name. The strawberry gallbladder.
Ah, yes. Cholesterolosis.
Is this related to the stones?
It's related to cholesterol metabolism, but not necessarily stones. You can have a strawberry gallbladder without stones. The pathology here is about macrophages.
The immune system's cleanup crew.
Right. Macrophages start gobbling up excess cholesterol in the bile. They get stuffed full of fat. We call them foamy macrophages. These cells accumulate in the lamina propria, a layer of the gallbladder wall just under the surface.
And what does that look like?
Well, the background mucosa of the gallbladder is naturally red and velvety. These cholesterol-stuffed macrophages appear as tiny yellow specks. So you have yellow specks on a red background.
Like the seeds on a strawberry.
Exactly. It's a classic one-liner in pathology lore. If you see strawberry gallbladder, the answer is cholesterolosis.
Is it dangerous?
Surprisingly, no. Unlike the porcelain gallbladder, the strawberry gallbladder is generally benign. It doesn't really cause symptoms on its own, and it doesn't turn into cancer. It's more of a curiosity than a catastrophe. It's just a sign that there is a lot of cholesterol floating around.
It's funny how we have these food analogies. Strawberry gallbladder, porcelain, well, that's dinnerware.
Yeah.
But now we have to talk about the terminal endpoint. The thing the porcelain gallbladder warns us about. Gallbladder carcinoma.
This is the final transformation. Gallbladder carcinoma is a grim diagnosis. It's not the most common gastrointestinal cancer, thankfully, but it is one of the most lethal.
Why is the mortality rate so high? Is it just an aggressive tumor type?
It is aggressive, typically an adenocarcinoma forming from the glandular lining. But the real problem is presentation. Think about the symptoms we've discussed today. pain after eating, maybe some vague abdominal discomfort, maybe a bit of weight loss.
Those sound like the symptoms of having stones.
Exactly. Gallbladder cancer masquerades as routine cholecystitis. It hides in plain sight.
So a patient might think, oh, my stones are acting up again, but it's actually cancer.
Yes, and by the time the symptoms are severe enough to distinguish it from just having stones, maybe jaundice or a palpable mass, the cancer has often advanced significantly. We call it late presentation.
And structurally, the gallbladder is in a bad neighborhood for cancer, isn't it?
It is. The anatomy works against us here. The gallbladder is plastered right against the undersurface of the liver. The wall of the gallbladder is relatively thin. It doesn't have a thick muscle layer to hold things in.
So it's easy for the cancer to break out.
It spreads early, it grows directly into the liver, it invades the biliary tract structures, causing jaundice. It spreads to the regional lymph nodes.
So by the time you catch it, it's often already moved out of the house and into the neighbors.
Correct. And that brings us back to the risk factors. The sources emphasize the connection to long-standing history. It's rarely a sudden event. It's linked to chronic stones, chronic inflammation, and that porcelain gallbladder we discussed. It's the result of years, decades of irritation.
It really emphasizes the importance of not ignoring those chronic symptoms.
Absolutely. The silent stone isn't always silent. It whispers for a long time before it screams. If you ignore the whispers, the indigestion, the colic, you allow that chronic damage to accumulate.
So let's recap this journey because we've covered a lot of ground. We've gone from a crystal to a cancer.
Sure. Let's connect the dots one last time.
It all starts with the stone, cholelithiasis.
Right. Either you have too much cholesterol leading to yellow stones driven by the 4Fs, or you have too much bilirubin and infection leading to pigment stones.
Then that stone moves, it causes a blockage, acute cholecystitis.
Which is an ischemic event. Remember, pressure kills the tissue. It's not just an infection, it's a strangulation. And it's a complication engine leading to pus, gangrene, perforation, or even those wild fistulas into the bowel, causing an ileus.
Then we have the slow burn, chronic cholecystitis.
Where the organ shrinks, scars, and fibrosis takes over. The wall becomes thick and leather-like.
Which can lead to the visual markers we discussed.
The strawberry cholesterolosis, which is benign but visually striking, and the porcelain calcification, which is a rigid, calcified wall that serves as a warning sign for cancer.
And finally, the silent killer, carcinoma.
Which hides behind routine symptoms until it has invaded the liver, making it a very difficult disease to treat.
You know, what stands out to me looking at this whole picture, it's the strange beauty of the language we use to describe such a painful process. We talk about pearls and porcelain and strawberries.
It is ironic. We use these delicate, almost artistic terms, concretions, porcelain, strawberry, to describe the body's attempt to handle chronic irritation. But beneath those names lies a very dangerous progression.
It's the body trying to wall off or clean up or harden itself against damage. From forming a smooth stone to calcifying a wall into porcelain. It's protective in a way, until it isn't.
That's a profound way to look at it. The pathology is often just the physiology trying to survive under difficult conditions, until the compensation becomes the disease itself.
And that is a perfect place to leave it for this deep dive. Next time you feel a twinge after a heavy meal, or you see a piece of porcelain, you'll have a whole new appreciation for the geology and drama happening under your ribs.
Indeed. It's a reminder that even the quiet organs have a story to tell.
Thanks for listening to this deep dive into the silent stone. We'll see you on the next one.